everyone. I'm Leslie Cornwell, Certified Nurse Midwife with Empowering Midwifery Education. This next section has to do with hormonal contraception. A legal disclaimer we put at the beginning of all of our presentations. This information is for educational use only. Content is not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as accurate as possible, but we claims, promises, guarantees of the adequacy for your unique situation. Course objectives: the student will be able to understand why it's important for midwives to know the different options for hormonal contraception, particularly at 6 weeks postpartum, to be able to verbalize what the different contraceptive options are, be able to talk about why the mechanism of action, the effectiveness of the different hormonal contraceptions, and the risk and benefits of choosing one over another. The importance of hormonal contraception: it's a great option for some people. We have barrier methods, we have non-hormonals, we have contraceptions that are hormone-based, we have sterilization. There's a lot of different birth control options available. There's the natural family planning, the breastfeeding, lactation, amenorrhea. This section we're going to focus on the ones that have to do with hormones. A lot of times it's given to the mother to make it so she cannot ovulate, so that the sperm can't get to the egg, can't get to an ovulated egg that can be fertilized. So there's a key focus with hormones, whether it's Nexplanon, whether it's a Mirena, whether it's an oral contraception, it's the patch. They all are given estrogen, progesterone in combination or progesterone only to suppress ovulation. So what are the basics of contraception? Contraception can be many, many different things. Contraception can be orally, it can be implants, it can be injectable with a depot, it can be a condom, it can be sterilization, natural family planning. It's a very generalized word to help prevent pregnancy. The mechanism of actions, the effectiveness are all very different. Some are highly effective, some are not very effective, depending on your situation. So our goal as midwives is to talk about all the different options with our clients so that they can make the best decision for themselves. So there's the different types of hormonal contraceptions we're going to talk about. There's the Nexplanon, it used to be called the Norplant, and it's the implant. It goes into your arm, is placed by a CNM or an obstetrician in the clinic setting. It can last up to 3 years. It's a slow dose, constant release of hormones into the woman's body. The typical use failure rate is less than 0.1%. So it's a very, very effective, low maintenance option. Anything with hormones are going to have a side effect potential of irregular bleeding for a while till their body gets used to it. Eventually it becomes short, light periods. But everybody's different. Everybody handles hormones different. Some people with mental health disorders, hormones are very sensitive to their body. Breast tenderness, moodiness, depression. You just have to look at individual situations and what they're looking for. The depot shot can be given once every 3 months in the arm. It's an IM injection in the clinic. It's a long-acting progestin that can be given. It's around 96% success rate. You can do combination oral contraceptions. You can do progesterone only contraception. The biggest thing is when they're 6 weeks postpartum, we do encourage the progesterone only if they're breastfeeding because it's used in combination. There are some studies showing with estrogen birth control options and slightly decreasing the milk supply. So if she's breastfeeding, our goal is to put her on something progesterone only for a while and then combination once she's done breastfeeding. This is a more common option that people will pick. You take a pill every day, especially with a progesterone only. You have to take it the same time every day for the effectiveness. It's a higher dose of hormones because you have to make up for everybody's gastric emptying dynamics. So we got to be a little more careful with anything with hormones with a history of blood clots, cancers, bleeding disorders. We want to be really careful when we're considering hormonal contraceptions, particularly the combined oral contraceptions. The effective rate is around 93%, and a lot of it has to do with human error and making sure you take it every day pretty consistently. When you start forgetting and missing, you can have some breakthrough ovulation and get pregnant. The other thing is to think about there's so many different types of oral contraceptive options. There's monophasic, biphasic, triphasic, hormone combinations. There's different brands, there's different generics, insurance accept different ones. So this one you have to really know the different options in your area and what makes the most sense for the clientele you're serving. So the progesterone only is more used for breastfeeding women or women that can't tolerate estrogen very well. It's not as effective as the combination. You have to be very careful of taking it at the same time every day because it's really just using one of the hormones. It's called the mini pill in a lot of situations. So this is a great choice for someone that wants a little bit more added to breastfeeding postpartum. So the patch, Depo-Provera is the brand name. It can be worn on the lower abdomen, butt cheek, shoulder. I've seen it in many different places. A lot of women like it in the lower abdomen, buttocks, because they can hide it. It has to be prescribed. It releases slowly. Progesterone and estrogen into the system. You change the patch once a week for 3 weeks. The 4th week you don't put a patch on, and that's when the period, the breakthrough bleeding comes. And then after 7 days you put another patch on, and every week you just switch it out. It's around similar to an oral contraception, around 93% effective rate. Emergency contraception isn't usually recommended as a preventative option. It's for someone that's using condoms. The condom broke, they were raped, there's spontaneous sex and using withdrawal, and then they have pre-ejaculation. It's an option to use 24 to 48 hours after unprotected sex and wanting to prevent pregnancy. So a lot of times as midwives we don't talk about this with our contraception options when we're trying to be proactive, but it is available for some people that their current method didn't work. So the potential risk and benefits, there's a lot to think about with becoming pregnant and using hormonal, using non-hormonal contraceptions. Everything is about a risk and benefit option. So we have to talk with our families and talk with our moms. If she's got 3 kids and life is busy and has a hard time taking her prenatal pills throughout her pregnancy, oral contraceptions may not be the best route for her. Our job is to talk about the risk and benefits, her lifestyle, how unlikely she wants to get pregnant in the next year or so. Does she want any more babies at all? Does she want one 6 months from now? Does she want one 3 years from now? How effective of an option does she want to use? We have to really have a great conversation of the pros and cons of using hormones, non-hormones, hormonal options, barriers, sterilization. Really just understand thoroughly what are the pros and cons of using the different options for pregnancy prevention. So the benefits, obviously with hormones, it is a great option for some women if they have painful periods, especially as teenagers. We talk a lot to parents that the birth control may not be given to prevent pregnancy. It may be given as a treatment option for dysmenorrhea, for heavy periods, for painful periods, for frequent ovarian cysts, pelvic pain. Some people with mood disorders, it's actually better when they're on hormones. Some people it's worse. There's a lot of options with endometriosis, really decreasing the menses, the flow, the inflammatory response. There is some evidence showing it helps protect against uterine fibroids. It does not protect against sexually transmitted infections. That would be barrier methods, but it can help by some situations if there's pelvic inflammatory and disorders occurring, to consider this option, not just for pregnancy prevention. So some of the things to think about anytime there's hormones, estrogen, progesterone, cardiovascular disease, people that smoke, people that have hypertension, people that have bleeding and clot disorders, you want to be very careful of risk and benefits if they've had a history of stroke, risk of MIs, anything having to do cardiovascular. It's always a risk benefit analysis, because a lot of times, even if you're considering, and it's a big debate across the medical community, that if this is the only option that works for them, and them getting pregnant is a higher risk than the risk of the stroke, the risk of the hypertension, smoking for clots, you need to always have a really good analysis with your clients and ultimately let them make the choice and document really well. Metabolic changes, some women will have some weight gain, some women will have lipid panel changes with the estrogen progesterone combination. It's usually short acting. It's if you stop the medication, it usually starts to stabilize. Everybody's a little different. There was some studies with bone density loss with the Nexplanon long term, where the baseline does come back after not using for a while. So there's still a lot we have to learn about short term, long term effects of hormones. We tend to, as midwives, take care of clientele that want more natural base. They want a little more control over their body, but there are certain women that have painful periods that have that hormones work really well for them. They help to stabilize that risk of postpartum depression and mood disorders. So you just have to really have a good understanding. If the woman's like, I love Sprintec, I want to take Sprintec after I have the baby, we're done breastfeeding, she knows her body and she knows what has worked for her in the past and what she would like to start. Neoplastic disease, this is something you need to think about with cancer risk and helping to decrease the concerns. The major risk, they just don't know with a lot of studies how long to be exposed. Does the issue resolve with time? It's so interconnected with breastfeeding and pregnancy and spacing and the medications. It's such a co-founding family history, lifestyle choices, obesity, stress. There's so much that can affect cancer. So you always have to be careful of estrogen, progesterone, implementing supplemental hormones in the body, what it has as a risk of developing neoplastic diseases. So just as an overall summary, there's a lot of great options for women, particularly with hormones, not hormones. So there's the hormone options. You could do the Depo shot once every 3 months. You could do an IUD. You could do a Mirena that can stay up to 7 years in the uterus. You can do the oral contraceptions. There's progesterone and there's combination depending on if they're breastfeeding, they're not breastfeeding. There's the Nexplanon that can go in the arm. There's the patch that can be placed on the skin. Everybody's different depending on if they're a teenager, if they've had babies before, their insurance plan, their lifestyle, their personal habits, routines, their comorbidities. You really have to look at everything in a very thorough analysis and do a risk benefit of what option of birth control is the best choice to consider for your client, and you guys make a shared decision making. So we always stress that it's good to do preventative medicine. We want to be proactive. We want to do STD screenings, whatever route you choose, reinforcing that condoms and barrier methods are reduce the risk of sexually transmitted infections, but all the other options do not have a barrier, do not prevent against those things. So it's really important to screen them for intimate partner violence, screen them for cancer, screen them for risk factors. If they have frequent sexually transmitted infections, it's usually not a good idea to give them an IUD, whether it's a Paragard or a Mirena, because it increases the risk of pelvic inflammatory disease with that string and the route for the sexually transmitted infection to go up inside the uterus. So you always have to have a thorough analysis at 6 weeks, thinking about their unique situation, their short-term, long-term goals, the comorbidities, the risk factors, their personal learning style, their responsibility, reliability. You really want to make sure that you're picking the right birth control option, particularly if you're adding hormones. You're doing more to manipulate their whole systemic estrogen progesterone levels. So you have to make sure the cardiovascular disease, the metabolic changes, are they a good candidate for this?